be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Welcome to tonight's Lung Cancer Living Room. So happy to see all of you here. Lots of new faces and lots of people that have been coming around for a long time. So welcome, welcome. Welcome to everybody online who might be signing in from hopefully some comfy place with a glass of wine or your favorite beverage, ready to listen to what we're going to talk about tonight. As most of you know, tonight is the much anticipated annual Best of ASCO. ASCO being the Association for Clinical Oncology, and it's a meeting that, or American Society of Clinical Oncology, it's the annual meeting that we talk about where all the people that are out there doing research get to come and present their data and tell us all the exciting things that are coming down the pike. So tonight we've got two very special people here with us. And before we jump into the presentation, I want to kind of forewarn you. Some of you have seen this before, some of you have not. We're going to dive into some graphs that look like you will not be able to understand what it is they're trying to tell you. But these amazing gentlemen sitting to my left will be able to explain it. But before that, Andrew, if you could just explain a little bit about the different types of graphs and what it is we're looking at so it doesn't look like a completely different language once we shine them up there.
Yeah, sure, and I think that's a good segue because I kind of call this the what exactly am I looking at tonight section. Mm-hmm. So there's kind of several things, and we're going to be flashing, a lot of graphs, but really the point is, what does that all mean for me? And so I thought I'd start by just talking about kind of the three main graphs that you'd see from ASCO. And the first two that I'm kind of showing here are graphs from clinical trials that were actually part of ASCO that are focused on how individual patients, what happens to them in a clinical trial. And these are graphs that are usually presented kind of early on when they're looking at a new drug and trying to figure out how it initially works. The first is on the top is called a waterfall plot because it looks like a waterfall kind of falling down when you really look at it from a big picture. But really what you're seeing there is every one of those bars is an individual patient's tumor who's received the drug that the clinical trial is interested in. And the big picture of this is when the bars go down, the patient's tumor got smaller. And when the bars go up, the patient's tumor got bigger. And really, ideally what you want to see is a lot of people on the right with the tumor getting smaller, and that means that the drug is having what they call a higher response rate. But I think it's important to keep in mind, when you're looking at this, how good is good? These are a snapshot in time. So these are just looking at one point. So really, combined with that is the swimmer plot. And the swimmer plot is what I kind of call trying to put a patient's story out in the best graphical representation it is. So each one of those lines is actually a patient who's been on a treatment in the clinical trial. And it's showing, unlike the waterfall plot, which just shows a single point in time, that what's happened to the patient since they started on the drug. And the further the line goes to the right, they're swimming along, they're still on the same drug. And if there's an error at the end, it means that they're still continuing on that drug when they stopped looking at the clinical trial. So this allows kind of people to look at things. They put a lot of marks on these bars. Basically, they just tell when did a patient start having their tumor get smaller, and then after that, how long were they on the drug. So it's really when you put these two things together, does a drug make a tumor smaller, but also how long does it keep that tumor smaller? We really start to see how effective treatments are. And so really kind of putting those two things together and looking at the bigger picture is a lot of what we'll be talking about tonight. And then I think, those two graphs are looking at individual patients, but really some of the most important things that we get from these clinical trials is when we look at the whole groups of patients, everybody that was part of a clinical trial. And this is really when we go to what we call a survival curve. And what happens in a survival curve is that each one of these lines are patients who received one of the treatments on the clinical trial. And a lot of later stage clinical trials compare two treatments to each other. So what you're seeing here is at the top of the graph, everyone is doing fine. They haven't had their tumor get bigger, they haven't had progression, or they haven't passed away. And at the bottom, the opposite is true. So as time goes on, things happen to patients, and that's when you see dips in these lines. So it allows you to see what's happening to the entire thing. The better a treatment is, the further that line will stay toward the top, where everybody's not had progression and things haven't happened, they're still successfully on the treatment. So you can kind of tell, how dramatic a treatment is an improvement over another by looking at the gap between those two lines. So what you really like to see, the big picture looking at these, is the further one line is away from the other line moved up, it's a bigger effect, and that drug is that much better. And so really that translates to improved survival and is really what we see at the very end of big clinical trials when drugs start to get approved and start given to patients. And this is kind of, I say, the meat of a lot of presentations. So really just kind of, starting out with a basic thing, looking at, how they look at individual patients and then groups of patients to try to see it. But, it's kind of an orientation, but we'll talk more about, what these things mean as we go along. But I thought it might be kind of nice just to show people, what exactly are we looking at. And do you have anything to add, Jacob?
Well, I'll just say before we start going into this, one of the most common questions I get is something where somebody is asking me to predict what will happen.
Right.
If we start this drug, how's it going to go? What are the side effects going to be? How long is it going to work? And all of that. Now, this is impossible to say for one individual. I mean, we went out of the room. Michelle, Rick, totally different experiences with the same drug, same type of diagnosis. Why? Well, that's still something we don't know the answer to, and that's something that we're studying. But how do we take that, and then as an individual, for me to be able to predict what's going to happen for an individual, this is impossible. Now, when we're looking at the data, we're going to see averages.
Yep.
But how many people in this room feel like they are average? Now, we don't know, right? So when we're talking about the data, these numbers are not the numbers for everybody. Right. This is an average. Now, this is an outline. These are essentially the slides for a talk when we reviewed the ASCO data at Dana-Farber in the thoracic group when we did kind of our own review. Now, we did this as part of our discussion about pathways as well. So we as a group get together, we review everything, what the outcomes look like, what the side effects are like, what the costs of the drugs are as well to the healthcare system, although I will put a little caveat there in saying that, in my opinion, it is not the doctor's job to control costs. It's our job to provide the best care for any individual in front of us. That being said, when you have two things that are essentially comparable, then cost is something that our healthcare system needs to figure out. But we take all of this into account in talking about what we think the pathways should really be, what should be the defined treatment in any given scenario. And so some of this was a part of that discussion. So this, we'll jump right in. So this is non-small cell lung cancer. Neoadjuvant means treatment before surgery, adjuvant treatment after surgery. This is a study that was presented by my colleague, Dr. Kwiatkowski, looking at atezolizumab, or Tecentriq. This is an immunotherapy. We know that these immunotherapies have worked very well in stage 4. So now we're saying, well, what if we do this actually sooner in an attempt to shrink things down and get a response to therapy, meaning a shrinking of and killing of some of the cancer cells, before then going to surgery. And so Dr. Kwiatkowski presented this data. This is a waterfall plot, and this is really kind of what you want to see from a waterfall plot, in that all of this is down. Now you'll see on the left side, it says percent pathological regression. So that is the amount, the percentage that there appears to be a response within the tumor. And I'll also say that when looking at this, when you cut out a tumor, it's not 100% live cells. So even without getting some treatment, cutting that out, we will see some dead cells within there. So, but that being said, you see that there are some with really dramatic shrinking of the tumor or a dramatic response to the tumor. And one of the concepts is major pathologic response. So that's when less than 10% of the cells within the sample are considered live cells versus those that have been killed. And so when we see something where 95% of the area of that mass appears like dead tissue, so 5% then of viable cells is what we would say. So that is major pathological response. And so they kind of looked at that as well. Side effects of atezolizumab, this kind of fits with what we generally see. We expect there to be some side effects. In fact, when you treat somebody with placebo, you see side effects, right? So what gets attributed to the drug versus what gets just, someone who's living their daily life, let alone someone with lung cancer who is dealing with some of the effects of cancer or some of the effects of other aspects of treatment and such. But there are certain things when we look at the side effects of two different arms. So one arm that gets the treatment versus one arm that gets a different treatment, and what the side effects differences are between those two, then we can see, well, these are things that seem to pop up more. So with the immunotherapies, certainly side effects that we attribute to the immunotherapies. And we see some of that with this, but generally extremely well tolerated. Yes?
Is the PD-L1 still a requirement for this immunotherapy drug?
Good question. So you're right, this is a PD-L1 directed drug, but it did not require that as part of being in the study. Is that what you're asking?
Yes, yeah. Are you seeing success?
So different with different studies, but generally speaking, so PD-L1 is a receptor on the tumor cells. PD-1 is a receptor on immune cells, T cells. And what these drugs, the PD-1 inhibitor, PD-L1 inhibitor does is block the interaction of those two receptors. So those receptors are in some ways like an ID badge on the cancer cells, where they tell the immune system, no, I belong here. So cancer cells get mutated, they look kind of different. Immune cells come by and say, hey, this doesn't quite look like a lung cell. And they show the PD-L1 is like that badge that makes the immune system go, okay, carry on. Generally speaking, although there's still a lot for us to understand more, about this, generally speaking, the higher the PD-L1 expression on those tumor cells, the higher likelihood of having a good response to the immunotherapy treatment.
At all points.
It's also who's responding to surgery.
Yes.
Who's having a total response to surgery and not needing chemotherapy or immunotherapy or anything else, because we're seeing now that,
If you use this
in many cases, they need the therapy as well.
Meaning that when they get surgery, then the chemotherapy after that.
Like, will we know that? I guess that's a good question.
Or
'Cause
before,
but that's what they're saying. If you're treating here with IO prior to surgery, is that better than treating in the after surgery setting, right? And looking at is the response.
Yeah, and so we still don't really
know.
have an established answer to that.
Right.
I mean, there are various studies looking at treatments before surgery, and there are others looking at treatments after surgery. The established standard of care at this time is getting surgery and getting chemotherapy after for 4 cycles. Now, I should really say we're talking about really a specific range. So we're talking about early stage lung cancer that's bigger than 4 centimeters, and then up to like 3A, resected 3A lung cancer. Now, the studies as far as neoadjuvant being before or adjuvant after differ in some ways, but those are both being studied. And Dr. Casconi is, from MD Anderson is doing a lot of this work as well, neoadjuvant therapy. So this is a study she presented looking at nivolumab. So this is a PD-1 inhibitor. So atezolizumab on the other one was PD-L1. This is PD-1, but both within that immunotherapy, or you'll hear the term checkpoint inhibitor category. And she looked at nivolumab versus nivolumab plus ipilimumab, and so that combination. And this is a chart you see on the left side is looking at major pathologic response. So you see that the green is greater than 10% viable tumor in the 2 bars there on the left. And the one on the left is Nivo, then there's Nivo-Ipi is the one next to that. And the red was between 1 and 10% viable tumor. So red and blue, and then blue is 0% viable tumor. So considered a complete pathologic response, no tumor that appears viable or living at that time.
And this is where we were talking about in some previous living rooms about some of those combination therapies. If you put, 2 of these drugs together and take a look at it, do they work better than independently?
Or does one give the other a boost that they wouldn't have normally had?
Yeah, go ahead.
No, I was also saying, playing off of what Jacob was saying earlier too, is also when you combine these drugs, how does it change the side effects of them? And that was something that was happening here because they saw that perhaps the tumors got even smaller if they gave the 2 drugs together, but there was a slight increase in the amount of side effects the patient had. And so it's kind of looking at that whole picture, we get a higher response, but what does that mean in terms of day-to-day?
Just curious, this is for my own, I'm just curious. When they do that and the side effects do rise, and I don't know how much worse they were, is that something that they go back and poll the patient about, like during the trial, to ask them how much they mind? Like, do they care?
Well, okay,
if it's working better?
So
But I mean,
in
we
the
ask
studies,
them. Yeah.
yeah, in the studies though, so there's toxicity, which is not what you're saying, but then there's also quality of life. And so some studies incorporate a quality of life aspect where people fill out surveys as part of being on the study to say how this has impacted their lives, what symptoms they're describing. I mean, that can be a part of it. There can be some overlap in that where symptoms are described during as far as the side effects experienced on the drug as well. EGFR. Now, this is relevant to a lot of the people in the room. This was a study looking at ramucirumab plus erlotinib, which is Tarceva, versus placebo plus erlotinib. So a lot of questions we get around clinical trials is people say, wait a second, I don't want to be getting placebo. So when there is a placebo used, it is almost always in this situation. So it's a randomization, means that there's a way of defining in a as random a way as possible which arm of the study people end up on. You cannot choose. So, but both sides are getting erlotinib, both sides getting standard of care, and then one arm gets the ramucirumab, the other one gets placebo. And this was the progression-free survival curve to this. So now on the bottom there you have time, and on the left side is the probability or percent. And so when we see those curves separate out, that represents a difference between the 2 groups. The higher, the better. And the best case would be a line just straight across the top, because that's people whose cancer has not grown in any way for the duration of the study. What we see here is that the erlotinib with the chemotherapy looked better than the erlotinib alone in the duration that it controls the disease. This is a forest plot, which we won't really dive into. And this is looking at PFS2. So this is, PFS is progression-free survival. So that is the duration of time before the cancer progresses, before it grows. PFS2 is the duration of, they're defining it as from the start of treatment to the time that it grows for the second time. And that also looks like a separation there, which is encouraging. We don't have overall survival, which is ultimately, of course, very meaningful. But this is, so this is a study from last year, just to give context. And this was erlotinib plus bevacizumab. Bevacizumab and ramucirumab are similar, are the same class of drugs. And we see progression-free survival advantage here. But the curves then come together when we're talking about overall survival. So for some reason, this drug has caused the disease to be controlled for longer, but in this specific circumstance, didn't end up in an overall survival difference.
Benefit.
So, although this looks promising to see this, and may very well be, next year, who knows, maybe we'll be talking all about this, there's still more to play out to this. There's still more to gather on this. Now, the other thing, well, I'll come to this. I'll mention this one, and then we can kind of break for a discussion around all of this. but this is gefitinib versus gefitinib plus chemotherapy. So everyone's getting the gefitinib. Half of the people are getting chemotherapy also with it. These are the qualities of all the people enrolling, and this is the waterfall plot. So we see almost, a lot of down, which is very good, and we know that gefitinib tends to work very well for those with an EGFR sensitizing mutation. And we see the curves separate out again. So there were people that saw this data and then came in saying, oh, should we be adding chemotherapy? And this is where people will see new research come up. They're on a treatment that's working. New research come up and go, oh, no. Can I switch? I want the new one. And, Tina did very well on just single drug. Would she have done better with chemotherapy? Well, it doesn't sound like it, because it sounds like things have been very good for a long time already. And this is where, when you have individuals that are doing well on a drug, changing over to something new just because is unlikely to be the answer in things, but it drives further kind of what happens down the line.
So I think the good news is there is a lot of things happening in lung cancer. So if you take nothing else away, take that away. And I know most of you in the room heard tonight how it relates back to you, whether it's by your mutation or some of the new mutations and fusions coming down the line in immunotherapies, small cell, if anybody's watching with small cell. New drug was just approved a week ago or 2 weeks ago in small cell, so things are really happening there. It's having cancer is not exciting, this I know, right? But it's an exciting time for lung cancer, and that things are happening fast and furiously. And second thing I want you to take away, and you're looking, and I hope, is as you're looking at all of these charts, and we saw a lot of the waterfall, charts, plots, whatever you call them today. Don't be afraid to think about clinical trial as part of a treatment option. It's so very important. None of the drugs that any of you are on today would be available to you were it not for people like you who entered these clinical trials, right? I kind of see the way clinical trials are happening today, especially with some of the results that are coming out. They are kind of more personalized. The way clinical trials are being designed and rolled out is becoming more patient-friendly, more targeted to individualized subgroups of patients. So if nothing else, please, consider them at some point. I know there's some people in the room right now who are on, certain studies or trials alongside some of the therapies they're on, which is a huge benefit. So it's just something to think about if you ever come to that point in the road where you think clinical trials might be a right, time for you.
And keep in mind that a clinical trial, if that's being discussed, it's because that is considered the best treatment for you.
Right.
It is not to advance the sciences. Hopefully the drug works for you and therefore demonstrates that it's effective and other people benefit.
Correct.
But you're not going on a trial to help society.
Yeah.
Right.
Yeah.
Right.
You're going on it because as a
Right.
treatment option for you.
Yeah.
And you're remembering that you need to be healthy sick to get on a clinical trial.
Healthy sick.
You can't be sick, because then you won't get in.
The time to start looking for clinical trials is having that discussion as early as possible.
Yeah.
And for that reason, that's a great point.
And to Danielle's point about the good news about lung cancer, more new therapies and drugs have been approved in the last 4 to 5 years than the last 5 decades. So if we just keep going at that pace, or exceed it, I mean, we're in pretty darn good shape.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest, like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.